Thank you, sir. I think the slides are visible.
Yes, we can see.
Yeah, thank you. Thank you, Shivasa, sir. Thank you, Dr. Narasimha. Today, I'll be speaking on the evolving diagnostic landscape in metastatic prostate cancer. We'll be touching apart from the metastatic setting. We'll try to see in locally advanced disease also. So the diagnostic landscape is more related to the genetic things which have come up in the last few years. And my talk is mostly going to relate to the kind of mutation testing which we do and a newer thing which have come up because of that. So we know metastatic prostate cancer is a biologically heterogeneous disease, and this is something which, apart from other cancer, this is something a quite biologically active disease. If you see a metastatic CRPC patient, approximately 90% of the patient, they have some kind of genomically aberrant pathways. And there are different pathways which have been found in metastatic prostate cancer, like AR pathways, that is androgen receptor pathway, PIK3 pathway, DDR, WNT, and cell cyclin signaling pathway. So this is a small chart which shows about a multi-institutional study in which they had done a profiling for nearly 150 patients in CRPC state. And you can see different pathways are activated in a metastatic setting, and the percentage you can see varying from 18% to 72%. But the main thing which we are more looking at is the DNA repair pathway, because that is something which is the most important active pathway. So approximately 23% of the mutation were identified in the DNA repair pathway. That is something which we know, which we can target. And we are looking at not only BRCA1 and 2, we are looking at the other genes like ATM, RAD51, FANCA, MLH, MSH2, and CHEK2, which we'll be taking up later on the topic. So this is a way to tell us that when you talk about mutation in DNA repair pathways, it leads to something known as genetic instability. And this genetic instability leads on to tumor growth proliferation. So there are different ways the pathways are there. So you have single pair, we call base excision pair. We also can have bulky adducts leading on to formation of nucleotide excision repair. Then the mismatch repairs, mismatch insertion and deletion, which can lead on to what is known as mismatch repair, which is commonly mentioned as MLH1 and MSH2. And the important thing which we are going to discuss is the DNA double strand breaks. So there are two types of breaks. One is the homologous recombination repair pathway. Another is known as non-homologous end joining, or we call NHEH. The key mechanism, if you talk about DNA double strand break, is the homologous recombination repair, which we'll be addressing as HRR. The HRR is not only including BRCA1 and 2, there are named genes, mutations are there like ATM, CHEK1 and 2, RAD51. RAD51 further has got multiple different types, and PALB2. Now, how do we identify this HRR? Because there are different terms nowadays being used. One is known as a simple germline or somatic BRCA mutation. Then we have a panel of HRR gene panel, and there's something which is nowadays come up in a big way is HRD genomic score. And what is the use of us different things? Remember, we are now looking at this particular gene mutation in certain subgroup of our cancer patient, like in pancreas or hepatobiliary, I'll say. Then you have in prostate, ovary, and breast. We don't use HRR and HRD in almost every one of them. There are certain areas where HRD is used, certain area where HRR is used. But we normally look at something known as HRD or genomic score, because it is day by day becoming a prominent score, because it identifies the pattern of genomic damage. It's something, and these tests are principally based on LOH, we call a loss of heterozygosity, and typically includes BRCA analysis as tumor BRCA mutation. So A patient can be HRD positive but can be BRCA negative. Apart from that, the other important gene panel which we commonly use is the HRR, one a homologous recombination repair mutation gene panel. And there are basically there was a trial on a profound trial which was medically looking at it. So HRM basically is a there are different genes which are there, and you can see here the profound trial. They have given importance to 15 genes, which includes RAD, which was around 4, which is B, C, D, and 54L, and also the BRCA mutation. So what we do normally in our testing is we look at the genetic mutation by either way germline or somatic. And also we look at the HRR and also the HRD. HRD is something which is going to become a prominent in most of the clinical setting. So looking at the prostate cancer, how much is the frequency of these kind of mutation? So these was a small study where they had taken an archival and new biopsy sample of nearly 50 loco-regional and 53 biochemically recurrent and 350 metastatic patients. And what they found was the most common mutation you can see in this nearly 450 patient was BRCA2 was dominant both in a germline and somatic. So approximately around 15%. Germline at around 9%, 7.5 in a somatic. BRCA1 was less prominent. Then comes the ATM in germline and somatic. Then is a CHEK2. So BRCA2 is the most frequent altered DNA repair gene in the prostate cancer based on the this paper. So the incidence of germline mutation in genes overall, if you see, is around 12%. So this is small paper which looked at nearly 700 patients, and they had looked at those genes which are evaluable, which can be assessed. They found they had assessed 20 genes, and in the 20 genes they found that around 44% basically constitute is the BRCA2. And if you see BRCA1 and BRCA2, it is nearly 50%. But the next predominant is the ATM and the CHEK2, which was around 25%. So somatic mutation was also observed, but the total incidence when you look at the mutation in a metastatic prostate cancer was around 12%. So this is a matched sample analysis of blood and advanced prostate cancer tissue samples. You can see they had taken a blood sample, also they had taken a tissue sample, and you can see on the left side the genetic or germline alteration, and you can see on the right side the germline and the somatic alteration frequency. So when you see on the left side the germline alteration, nearly 19, the bulk of the patient who had basically BRCA2. On the right side also the BRCA2 was predominant both for germline somatic. So the higher frequency of DNA alteration identified through the matched tumor sample, germline plus somatic, it strongly argues that you should do a tumor genomic analysis in patients who are having advanced prostate cancer. So this is a genomic profiling of primary prostate tumors from the patient who developed metastatic CRPC. And you can see on the left side and the right side non-metastatic and metastatic setting. They compared 49 pairs of same patient tumor, primary tumor and metastatic CRPC biopsy. And there was a limited intra-patient heterogeneity was observed between the primary tumor and the metastatic CRPC. There was no significant difference in the mutations which were found in the primary tumors who developed metastatic disease or who presented with de novo metastatic disease. So basically it is trying to tell that you can use a archival tissue also for mutation testing. So you can see a cohort 1 and cohort 2. Cohort 1 was the patient who had without metastatic disease at original diagnosis, and cohort 2 had de novo basically metastatic de novo metastatic disease, and you can see the difference is not so prominent in these two particular group. Now, a very well-known trial, the PROFOUND trial, which we have, which had basically addressed the role of HRR mutation, addressed the looking at the safety and efficacy of olaparib, which is a PARP inhibitor. So this was the first trial which looked at a phase 3 randomized trial, which looked at the efficacy and safety of olaparib versus novel hormonal agents in patients with HRR mutant CRPC. The eligibility criteria only required failure of prior treatment with NHA or a metastatic or prior treatment with the NHA for metastatic PC or CRPC. So they had taken patients who were centrally reviewed for the qualifying HRR mutation in the tumor tissue, and there was no patient had not taken any prior treatment with a PARP inhibitor or DNA damaging cytotoxic chemotherapy. So they had divided into cohort A and cohort B. Cohort A basically looked at two important prominent mutation. One is the BRCA1 and 2 and the ATM. And they were given olaparib in a 2:1 ratio. And cohort B was basically other HRM mutation. Olaparib was also given in 2:1 ratio. So the primary endpoint was radiological PFS, and the key secondary endpoint was the overall response rate, the PFS by the BICR, and the time to pain progression and overall survival, and also looked at the safety and the tolerability. So this is the largest prospective trial, basically, which studied, which screened the patient for HRR in patients who are metastatic CRPC by a central tumor tissue angiostensin. So the prostate tissue, how they acquired it, they either acquired it by the from the primary tissue, or from the specimen which they got it from the TURP, or they did the metastatic biopsy. The sample was the sample required at the sample needs to be formalin fixed and paraffin embedded, and minimum tissue surface area was around 5 to 7.5 millimeter, and the minimum of 20% tumor content was required for testing. They did the DNA isolation from the archived samples. Bone sample which required DNA calcification was not good for the DNA quality, and so before doing the DNA isolation, they looked at the DNA quality and quantity, and the testing performance was done from the NGS and the that is Foundation 1 CDS NGS, and they looked at all the deleterious or suspected mutation. So what was basically the looking at this trial, the PROFOUND met its primary endpoint. The PROFOUND met its primary endpoint means that the olaparib showed that there was a significant improvement of the radiological PFS by the in patient who had altered BRCA1, 2, and ATM. That is a cohort A group. Now, what happened to the other group, that is the cohort B, cohort A and B group, commonly if you see on the right side, it also statistically significant and clinical meaningful improvement was seen in this group. When they combine both cohort A and B, you can see a difference of around 49% in 6 months and around 22.13% in 12 months. So what was looking at the PROFOUND data, the HRR mutation prevalence in the screen population, a qualifying HRR alteration was observed in nearly 27.9%, approximately 30% of the patients with, who had a successful test result. And here also you can see a BRCA2 was predominant of around 8.7%, BRCA1 of around 1%. So the when you talk about the prevalence of HRR mutation in genes which are included in cohort A was around 16%. Like I said, BRCA2 was a main factor, around 9%. In cohort B, the most common mutation which was found was CDK12. And remaining 11 genes, they looked at 15 genes basically, and the remaining 11 genes in cohort B was contributing only 6%. So the distribution of alteration in HRR genes within the randomized population reflected that observed in the screened population. Nearly 7.2% of HRR mutation randomized patient had a mutation in more than one gene. Most frequently, so there was not only that all the patient had only one mutation, around 7% mutation, they had one more mutation apart from it. So most frequently they were seen with BRCA2 or CDK12. Remember, these two are the prominent mutation in either of the cohort. BRCA2 was nearly 9%, CDK12 was around basically around 6%. So now, what are the current testing practices which we normally do for HRR mutation? Remember, we look at two important components. We look at the germline and the somatic component. And the commonly performed test is blood or tissue. And in a blood, we normally do the ctDNA testing. Also, we do the CTC testing. But remember, ctDNA and CTC testing, basically circulating tumor cell testing, is something which we are not commonly getting a good result, is not commonly performed. So patients were selected for the study based on the prospective tissue testing, and the first screening part basically used to include they used to take the sample to the foundation medicine lab, and then screening 2 basically looked at randomization and based and the patient were blood sample from enrolled patient for germline testing was also done. So screening 1 and screening part 2, basically the screening part 1, they looked at tumor and the plasma sample. Plasma sample, they looked at the ctDNA, and the tumor sample, they looked at the HRR gene mutation. The screening part 2, which was done after 4 weeks, basically they looked at the similar thing, and some of the patients, they did the CTC analysis at baseline, regular intervals on treatment on disease progression. The purpose was basically to see whether the ctDNA works in this group of patient or not. Plasma sample ctDNA blood samples have been collected for retrospective analysis, recognizing that tissue adequacy would necessitate a broader algorithm in practice. Remember, in a prostate cancer, finding a tissue sample at a time of metastasis is something which is very difficult. So the modality which they looked at, primary modality they looked in the profound was basically the tissue. So the profound basically they, like I said, they divided into cohort A and cohort B, and the qualifying HRR gene alteration was identified by prospective tissue testing using a pre-specified panel of 15 genes involved directly or indirectly in HRR. So they had cohort A, the predominant 3-1, BRCA1, 2, and ATM. Cohort B had basically the most prominent was a CDK12. Apart from they had used the different RAD51, PAL-B, FANCL, and CHEK1 and 2. So like I said, a total 15 genes were tested as a subset of the genes. Genes were selected based on the mechanistic role in the HRR clinical efficacy data, heredity risk, and the most characterized, the best characterized were the BRCA1, 2, and ATM, and genes in the cohort B were considered exploratory. So there is a evidence of clinical activity of olaparib in patient with alteration in genes other than BRCA1 and 2. This is what profound has shown. And so it is not like that only BRCA1 and 2 are the one who are going to respond. So 97% of the patients who were randomized were based on the alteration in 8 out of 15 single genes, and the exploratory analysis suggested that patient with BRCA alteration derived the most benefit. However, there is an evidence of clinical activity of olaparib in patient with alteration in non-BRCA genes. But gene level analysis is complex. It is difficult because the sample size is very less. You can see, like, RAD51, RAD54, the number of volume is very less. But you can see on this chart, you can see gene by gene the radiological PFS. BRCA2 showed a very good response. CDK2 also showed response, but less than what we see in other. ATM, which was part of the cohort A, was not showing good response. CHEK2 showed RAD 51B and L showed a very good response. Here the responses were almost on par with the BRCA2. So different gene, but the problem is that you cannot extrapolate based on this small chart because the numbers were very less. So core needle was the most common collection method, but had the lowest test success rate. Higher testing success rate were from the radical prostatectomy and TRP. So trephine biopsy had the highest success rate, but this was based on a very few samples and not representative of all bone biopsies, which were mostly core needle. So you can see here the trephine biopsy, the most common collection method in the whole system. So metastasis happens predominantly in the bone tissue, and the challenge which we face when we do a bone biopsy is that the success rate is not very high because of decalcification and trying to get the adequate DNA material. I think this is something all of us know, that the bone is not a good sample to be sent for genetic mutation. So for a metastatic sample, the highest success was there when you do the sampling from the lymph node, liver, or other soft tissue areas. You can probability of getting a tissue DNA is around 70%. But bone and lung are something which are challenging, where the probability of finding is hardly 40 to 50%. And remember one thing, archival tissue is something which is feasible, and you can think about sending it for the NGS analysis. Now, this is the small area which is going to, this is basically trying to tell us that the majority of the sample which are assessed in the studies were the archived core biopsy derived from the primary tumor. So this is the archival status. You can see around approximately 90% was archival, 9% was the newly collected. And if you see the primary and metastatic was hardly 15 to 16%, but primary was approximately more than 85%. And this is the way they collected the sample, and the majority was a core needle biopsy, and radical prostatectomy was the next. Looking at the organ, the major organ was the prostate, and lymph node was around 7%, whereas the bone was around 4%. And another chart which is very important to know is the sample age. So they had patients who were more than 10 years, approximately 15% were more than 10 years, 5 to 10% were the majority, which was around 30%, and 3 to 5 years was around 23%. So less than 5 years in this study group, nearly 50% of the patient, more than 50% of the patient, they were basically less than 5 years. Now, looking at the sample breakdown, when you talk about the newly collected versus the archived tissue, so in a screen patient, samples were mainly derived from the archive, which I mentioned previously, nearly 90% was archived, and in the metastatic setting. You can see here, newly collected around 9%, primary from the primary tissue of origin 3%, but metastatic 5%. In an archived, basically nearly almost all the sample which was collected was from the prostate. So a slightly higher prevalence of HRR gene alteration was found in the metastatic tumor tissue. Now, talking about the prevalence of HRR gene alteration in primary and metastatic tumor tissue. So they had when you compare the prevalence, they found that when you collected the tissue from the metastatic tissue as compared to primary tissue, primary tumor, the prevalence was around 32% in the metastatic tumor as compared to the primary, which was around 27%. So the prostatic tissue, it was the probability of getting a alteration was slightly on the lower side, but not significant. So talking about the patient HRR mutation tissue test success rate, So this is the patient flow through screening for HRR alteration with the central NGS. Remember, this study was a very big study, a global study which had taken patients from 20 countries. Cohort A had around 200, more than 200 patients. So nearly 4,000 patients, they entered screening, and nearly 4,047 patients, the samples were tested and reported, and they found that nearly 70% of patients, they were successful. But out of this patient, around 400 patients, 387 patients were randomized over 22 months, 250 in the cohort A and 142 in the cohort B. So HRR eligibility was not fulfilled in more than 3,000 patients, and only the eligibility criteria was filled in around 380 patients. The main reason for test failure in this study was, the most frequent reason for test failure was the DNA extraction failure. That means not getting sufficient DNA yield to proceed with the testing. So had pathological failure of around not adequate tumor content of around 22%. Insufficient DNA yield was there in nearly 45%, and failure after DNA extraction, that means the DNA quantity was not adequate for NGS, was around 22%. So a good number of patients had a failure in getting a DNA extraction. So now this is another thing which tries to give us an answer, is that from where we should take a sample. So test success was higher with the newly collected versus the archived sample. Samples derived from the metastatic site versus the primary tumor origin. So they have put up a chart where they have seen archived versus newly collected sample, primary versus metastatic. And the most common reason for test failure were different depending upon the age of the sample. Archived samples are more likely to fail at the stage of DNA extraction, and newly collected samples are most likely to fail at the pathological review. So during the review period, the high probability that they will get basically they will fail. So the proportion of samples with a successful test, you can see the newly collected sample scores better than the archived. And when you talk about from where you have taken, metastatic scores better than the primary tumor. Now, this is a tumor testing success rate by organ site. You can see on the right side the lymph node highest, then comes the lung, liver, prostate, and lastly is the bone. So majority of the samples, remember, were collected from the prostatic tissue. However, the testing success rate for prostate tissue was very low, around 55 to 60% compared with other organ types. The highest was in the lymph node. So the testing success rate for prostate tissue was relatively low versus other organs, which could be due to high proportion of prostatic samples were derived from the archived core needle biopsy, which had varying amount of tissue remaining in the block because many initial diagnostic workup was already done. A variable nuclear density of the tissue depended on the part of the prostate sample and the amount of tumor in the core. And testing success was lowest in bone, as we all know that because of the degradation of nucleic acid which can happen because of the decalcification. The highest success which we can get in a metastatic setting was in the lymph node sample. So this is the second important thing, is that when we are talking about the archived sample, how good is the success rate when they collected sample of less than 1 year, less than 5 years, or more than 10 years. So samples are collected over a broad timeline, like we have discussed that there was some nearly 25% of the patient where the sample was in the age of around more than 10 years also. So test success rate declined with sample age. However, 50% of the sample aged more than 10 years was still able to yield genomic results. So I think even if you get an archived tissue, we should not forget that, because nearly 50% of the people you can get the DNA testing. But the highest success rate was seen in more recently collected samples. Like in less than 3 years, it was around 70%, 66 to 70%, whereas older sample they had less probability that you will find a good DNA content because of nucleic acid degradation of impacted by the storage condition. So what are the key takeaway from this trial looking at the NGS of tumor tissue in that profound trial? That the tissue testing is recognized as a current gold standard, but is challenged in prostate cancer because by tissue fail rates by the NGS gene panel testing. So in the profound trial, analysis explored the impact of different factors on the tissue testing, including collection method. They look at the age, they look at what type of tissue to be done. And talking about the collection method, they found that the core needle biopsies yielded lower success rate than the samples from the prostatectomies and were the most common collection method in the study. Small residual tissue sample sizes barely reaching the minimum tissue volume input may be a limiting factor for successful test outcome. Talking about the age of the sample, older sample, less success rate. Successful testing was possible in both archival, because in the trial they found nearly 47% patient the archival prostate tissue they were able to get. But recently collected sample, those which are less than 33 years, the probability of getting a success rate was around 70%. Tissue was one which is most commonly tested, but testing success rate were higher for the metastatic sample than the primary sample, which may be due to higher cellularity and tumor content, and that most primary samples were archived. In profound, common reason for test failure were that sample did not meet pathological requirement or had insufficient yields of DNA after extraction. This highlights the critical importance of selecting high quality samples and optimization of tissue collection to improve the NGS success rates. So these are the basically looking at the quality of NGS based HRR mutation testing relies on the provision of adequate sample. You need to be, it should be optimally fixed basically within 8 to 12 hours, 24 hours in a 10% neutral buffered formalin. And this is the thing which is basically told to part of the pathologist workup, that the section has to be appropriately done, at least 50 microM section thickness, and for the optimal DNA extraction. And it should be reviewed by the pathologist to determine the adequacy, whether sample quality is sufficient with more than 20% cell and whether it has got more than 1000 cells. So pathologists must determine whether the specimen contains sufficient neoplastic material, that is more than 20%, and it has got enough tumor cell, that is more than 1000, for a test to be successfully conducted.
Sir, sorry for interrupt you. Can you conclude your talk?
Yeah, I think just one more slide. So this is the algorithm for the use of more than one diagnostic option. So we do plasma and tissue testing. Nowadays, most of the time we do both the testing to get a better result. And the preferred algorithm is that initially tissue testing is done, followed by a germline mutation testing if there is an insufficient sample or no tissue, and in the absence of validated ctDNA testing. So moving from HRR, BRCA to HRR, I think we have now gone beyond BRCA. We are now looking at other mutation also. And because ultimately, end of the day, there is a drug which is available which can be given to the patient. Now, these are the NCCN recommendation looking at which place we should do this mutation. So NCCN does recommend that in a high risk population also, early stage, you can do it. But in a metastatic CRPC state or metastatic hormone positive patient, we should do the BRCA mutation. This is the NCCN guideline recommendation where we should do the mutation testing. I think this is the last slide. This is just a sample report about it. Thank you, everyone.
Thank you, Tajinder, for an extensive review. It was appearing very difficult topic, but I think fairly understandable in this. I was just thinking that earlier period of there were hardly and nobody used to go for all these tests. I mean, do you think that it is going to be the future for all the genetic tests that will be done for all prostate cancers?
Ideally, yes, sir. I never used to do testing regularly, but I had started doing it in the metastatic CRPC state. Even though the NCCN guideline does put that you can do it in a high risk, local advanced disease also. But I feel that in a metastatic CRPC state, it has got a usage because there's one drug which is available. After in the last 6 months, basically, my experience is that out of 10, one patient will have mutation testing positive. Two of my patients, they came out to be check2, and one patient came out to be CDK12 positive. So 1 out of 10, the probability of finding the mutation even in Indian setting also. It is just that we are not doing it.
Yeah, right. I think maybe it was expensive, therefore it was not done, or?
So yeah, yes, sir. So why I am doing it? Because company is providing it for free of cost right now. So, but what you said is very right. The HRR testing will cost around 20 to 25,000. I think cost will come down once the utility or our usage also will increase.
Yeah, right. Well, thank you. Any other question by anybody? I couldn't see anything in the question and answer in the chat. Dr. Narasimha, anybody is there?
I think there are no questions in the question box, but excellent presentation, comprehensively summarizing the whole thing. I think I'll just make a comment here, mostly for the urology colleagues. Most of the times the initial diagnosis is by the urologist who does a biopsy, most often. So most of the times when we clinically know that we are dealing with a metastatic prostate cancer patient, we tend to take 3 or 4 cores, and then mostly to document, look at the Gleason and some small variations that are possible in the histopathology. But I think now that we have an actionable drug which requires a comprehensive tissue-based analysis, I think the time has now come where we'll have to sample more and more, even when we know that these patients are metastatic, and archive them properly so that they come handy when it is required.
Thank you,
sir. Yeah.
Yeah, right. Fully agree. I think we can